Good morning, everyone. I want to thank you for this opportunity. Just going to give you a little introduction. Whoops, let's go back one. How do I go back one? How do I go back one? There we go. Marianne talked about yesterday how interoperability matters. There we go, I can say that. Has 3 new exciting initiatives for this year. This is the most exciting one. I'm not biased in saying that. This is the payer-to-payer API. And what we're doing, I have a little bit of background before we get started just to set the ground. As we all know, the CMS interoperability rule dropped a little while ago. And although timelines have been shifted and priorities are shifting, there still is a drive to get payer-to-payer interoperability going. And through DaVinci, through Karen Alliance, there's been a lot of really good work on defining what needs to go to who, when, using FHIR, using various and sundry things. But one of the things that's missing is sorry, I've got a bad habit of clicking. Is the holistic approach. And that means what goes on before you get that data out to the DaVinci interoperability and send it across the wire, what the back-end processes are, right? And that's governance, that's policy, that's technical challenges that DaVinci doesn't touch because there's no way they can look inside your organization and say it. So for payer-to-payer operability, we're creating a work group to try to get best practices, get people together to say, hey, this worked for me, or I have this problem, how do I solve it? And get as many payers together in a room and say, hey, we can do this. We can make this work. So that's the payer-to-payer interoperability matters group, the payer-to-payer API. Our first year is just to get a group of payer stakeholders together to work towards solving these challenges and create a community of practice that will help guide discussion and create best practices to do that. We want to create actionable business governance, operations, best practices to get the data moving, to get people to the state where they can get data moving. And of course, create dialogue to find the gaps, because there's always gaps. We all want to say, yep, we're ready. No, we don't. We want to say, help, don't know what my next step is. So we'll develop the recommendations, and we'll get the payer implementation readiness. So I've assembled a wonderful group of people here. Whoops, and somebody skipped. There we go. Nope, I can't do this. It's not. There we go. There we go. I'm not good with buttons. I work in IT. Never mind. What I'm going to do is start with the first question of asking you where your organizations are in your journey towards interoperability, so where you are. But first, introduce all yourselves. We'll start with this man who I co-opted into this panel less than an hour ago.
Yeah, I'm Bob Oakley. I'm with Evernorth. If you're not familiar with Evernorth, that is the health services division of the Cigna Group. So that's our PBM, our utilization management, and care delivery and pharmacy organization. And I lead interoperability and strategy for our innovation organization.
Good afternoon. I'm Rob Alger with Kaiser Permanente. My area is health plan technology strategy. So I'm very interested in how do we want to ultimately not only consume data, but use data, and to what end?
Hi, I'm Desla Manchilla. I'm the manager of health data interoperability at the Blue Cross Blue Shield Association. We work both internally throughout our association and plans, or the system as a whole, to bring interoperable data to those that need it to be able to support the many functions that payers have a need for.
Hello, Nancy Beavin. I'm from Humana, Director of Interoperability, specifically provider and payer interoperability, and now payer-to-payer interoperability. Strategy, operationalizing what we have, and working on the next innovations.
Great. Okay. Well, the first question is the one I said. Where are you, and where do you see your journey towards interoperability happening for your organization? And we'll start with Nancy, because she's at it far away from me as she could.
We've been doing interoperability for an awfully long time. So We've been doing straight up data exchange for over 10 years. We started with proprietary interfaces because there wasn't anything else available. We went to an internal HIE and started using the HL7 and X12 standards. Now we are, we've developed over 20, I don't know exactly what the number is, over 20 FHIR APIs that are publicly available on our website for anybody to hit and to use. They include observation, patient, condition, coverage, ID card, the digital ID card, authorizations. Those are all out there for anybody that would like to go to www.developer.humana.com. We use those internally. We currently do prior authorization electronically with 2 vendors, and we use the FHIR standards for that connection. I think we've come a really long way in kind of getting past data can be exchanged today, right? So, and this is gonna, I think what we're gonna be able to do here with Sequoia and TEFCA is really scale the ability to share more data with more folks that haven't had that opportunity so far. And then once we have that data, now that we have that data, it's really about working on, and we've said it a lot here today and yesterday, and that's the workflow integration, so that the data we're sending and receiving is actually getting into the hands of the user on the payer side, or the patient or the member on the other side.
Great. Thank you.
So I think we've come a long way. We have a lot of things available, a lot of things we're connected to about half of our contracted providers electronically.
Fantastic. Desla?
So for us, I think I need to explain a little bit about our organizational structure to help understand what role the association plays. And Nancy's laughing, and I have to laugh too, because it took me years just to figure out what our structure was. So we, as the association, work with our 33 locally owned and operated Blue Cross and Blue Shield plans across the United States. And as you would expect, when you line up 33 of anything, everybody's at a different place. So we have some of those plans that are like the giraffes with their necks way out into the future, and some that are more on the tail end of that process. So we really work to, throughout our plans, to meet them where they are. And I'll give an example of that. The association operates what's called a clinical data exchange hub. It is at this point focused on CCDA documents and ADT documents, or ADT messages. And that's because that's where many of our plans are. Yet we have some that are so far ahead and really the leaders in the development of some of the FHIR uses that are in place today. So we kind of have to balance where we really find our work being done at the association level. And I would say that I think it's also important to consider that we know that leadership, as much as the rank and file staff and across the plans, really needs to know more and understand more about interoperability. I'll talk about that a bit more, but I think that for me, one of the things that I've really noticed is getting that leadership buy-in for funding of various projects, because when they have kind of a nebulous timeline that keeps getting changed, it's hard for them to commit. So I'd like for us to think about that as we go through this conversation as well.
So Kaiser, like I think almost all of the larger payer, and of course we're an integrated plan, we have a long history with interoperability dating back to the earliest HIEs, and certainly all of the work that's occurred recently with the APIs and FHIR. And so the mechanics of this, I think we're in a very, very good position to understand the mechanics, understand the nature of the data, the nature of the data sets. And I think what we'll talk more about, the part that I'm personally most interested in, is the so what of this. So what in the world are we going to do with this new data? What are the expectations of our members? What's the expectations of patients? What's the expectations of clinicians? How do we use this in onboarding? So it's much less about the mechanics of it And it's much more about, we will have more longitudinal data than anyone has ever had before. And so now that you have a brand new, shiny longitudinal data set, what do we do? And who has what expectations? So when a member says, yes, I'm changing plans and I'm authorizing you to send my data, what do they expect to happen next?
Yeah, and I like the way you describe that as mechanics, right? I think we're very well prepared to execute on this exchange. In terms of interoperability within Evernorth, we have everything from crumpled bits of paper to direct bi-directional communication within the EHR and within the physician's workflows, but not at scale, right? So scale is very difficult without a trust network, which is why we're very excited to see this work. But where we are in terms of our journey with interoperability is shifting the mindset in our executives, educating them, helping them understand that this is not a compliance initiative, this is a value initiative, and how do we put the patient at the center, right? These payer-to-payer processes really come down to how do we deliver the best value we can for the patient. We call them our customers because they're your patients in the provider space, but how do we do that in a way that doesn't create friction, doesn't create unnecessary drama when you're changing a plan, especially what we're talking about, where ACA Exchange, Medicare Advantage, these are people that have conditions, don't have a lot of understanding necessarily about this process. How do we take that burden off of them?
All right, great. I mean, you've talked about a number of issues that have occurred as you've built out your interoperability journey. None of you are new to interoperability because it's existed in one way or the other, from X12 messages to bits of paper flying through the air. Yeah. But when we get to FHIR, we're changing, to a certain extent, the paradigm we're working with by getting on-demand data as you need it, when you need it, that kind of thing. When you're moving towards this, what do you see is the biggest stumbling block that you've either addressed already and say, hey, we did it, or you're seeing coming up in front of you and saying, wait a minute, we need to address this and we need help? Desla, start in the middle.
Okay, so I guess there's a lot to say there, and you're asking for one. I probably will have to say two because I just can't stop.
Okay.
So the first is around the idea that technology alone is necessary, but probably not sufficient to solve the problem. So FHIR certainly is a key part of being able to move forward together. Yet at the same time, it's going to take that whole compendium of things like collaboration and policy, and maybe in many ways some culture changes within our organization. I think the last panel referenced this to some degree. We still have some of that talking between payers or payers talking to providers is a no-no, and that's not going to get you anywhere good. And we have to get around that thinking to really engage the individuals that need to make this work together. So, we have legacy systems that weren't built necessarily for the kind of data exchange that we envision today. And FHIR offers us that opportunity to really change that mindset. So I think that is, the beauty of FHIR. I think the other challenge that we really have to grapple with yet is the alignment of standards. So many standards, ID and all of the security and those things that really have to support FHIR. We have to come to consensus on those, and it's very difficult to come to consensus within the large four walls of our own organization, much less thinking about it across the industry. So standards alignment is a one that I don't think we can live without talking about.
The thing I worry about are data silos. So FHIR is a new standard. We're going to take data in FHIR, but I also have data sitting in EMRs. I have data sitting in claim systems. I have historical data in other formats and other places. So at what point do I converge this, or is that never going to happen because there's no business case that says I'm willing to pay for the convergence of these different data sources? Do they stand together, or are they going to stand completely independent of each other? And I'm going to believe that my AI strategy will read them all magically. Yeah, a little AI fairy dust. It'll solve almost everything, I'm told. So that's what I really have been thinking about, is we evolve standards for all sorts of good reasons in USCDI and the new data sets, but we're not bringing the legacy data along. And we have really strong legacy data stores sitting out there.
Nancy?
I think a couple of things. I'm going to do two, like Desla. I think number one is a paradigm shift for all of us that have been in interoperability for a while. So from a payer perspective, we have focused on being able to bring in encounter data. So we're HIPAA compliant, right? We can't really have a longitudinal health record because we may not have paid for all those claims. But we get the entire encounter record because we can use it for multiple use cases. So we can use it for risk adjustment, we can use it for quality, we can use it for claims review, we can use it for transitions of care and care coordination. You mentioned that with FHIR, we could go get an individual piece of data when we need it. So that's the paradigm shift, right? Is it better to get it every time one of our members has an encounter so that we can mine it for quality every single time? Or is the business case really to say, well, just go ask for it when we need it? I'm not sure what the answer to that is yet, but I think it's something we have to grapple with. Now, FHIR doesn't mean you have to go get one single piece of data at a time, right? We're working with a vendor now to implement CDEX so that we can replace their CCDAs that we're getting. We're still going to have to get CCDAs for a long time. Just like in my lifetime, fax machines are probably not going to go away, right? We'd love for them to. That's the goal, that's the mission. But we have to be ready to meet our provider partners where they are and their vendor partners where they are. So that's one thing. I think we just have to, I think there's a paradigm shift or change that we have to think about. Then second of all, what I just mentioned, and that is nobody's going to be 100% FHIR or 100% CCDA or whatever it is anytime soon. Because if you want, our goal is to be electronically connected to all of our providers and all of our patients. We have to do that with different tools that are available today and that we can, it takes two to tango, I say that a lot, and the other side has to be ready. So we are making sure that we're ready for any FHIR capabilities that our partners are ready to use, and we've implemented several of them. But we also have to still be ready with the other transactional types because not everybody's there yet.
Right.
Yeah, and I really like the thought of, we have these legacy information systems we have to bring along. Also, internally, we're building an infrastructure that allows us to exchange data between our lines of business via FHIR, but recognize that once we hit the outside world, it's the Thunderdome, right? It's whatever is out there. We got to be able to take it in. But the biggest limitation, I think, in our organization right now is getting that mind shift to, if you had the data, what would you do differently, right? If we knew that a customer that just enrolled the day after, if you knew the list of medications they were on that were going to require prior authorizations, and we can just go execute that before we even hit January 1st, or know that we have a patient that is non-compliant, but they have diabetes, that we can start and organize and shifting the resources to support them on day one instead of in September when they end up in the ER, right? So we're having to rethink our entire workflows. It's not just legacy data. It's that we've been doing risk adjustment this way for 20, well, not 20 years, but it sure feels like that. How can we shift to making use of the data on day one?
Yeah, I think that's really a great point. Payers have been in this mode of a latency between when we get a new member and when we have that first encounter to be able to get any information on them. That's what's so exciting about payer to payer, is to be able to know a new member has signed up on this day, and so now we can go ask for their information. And with that, we're working on our care management programs and our enrollment programs to say, with that information, we can identify the diabetics or the patients with COPD or the CHF patients or whomever it is that we want, the Medicaid patient that is a newly pregnant and needs healthy beginnings kind of engagement. To be able to proactively reach out and make that engagement before any kind of encounter happens, that's what we're preparing for, and really excited that we're going to get to change to that, how that's going to impact the quality of care we can give our members.
I think that's one of the things that's coming, and you brought it up specifically, is that suddenly you're going to have access to a lot more data. And with fire and with TEFCA in general, you're going to have access to millions and millions of data points, because suddenly you've had a member for the last 5 years, they were with someone else for the past 20 years, and you can go and request, hey, give me all of their data, and you'll get it. That's the exciting part. But it's not just one, it's all of your members now. And that's going to give you a deluge of data that really hasn't been seen before in the industry. What's it going to take to cope with that much data coming in that fast and that easily? Paul?
You've got a lot of confidence in how quickly we can move. That's the first one. And immediately you say it like that, I look out and I think of all the providers that are thinking about the mustache twirling parts of our organizations that are thinking about like what we can do differently now. And that's not where we're really focused. It's really on what is the data that we need to do this, right? That yes, there is a vision of like, hey, this data is liquid, it flows where it needs to be, when it needs to be there. But on day one, it's more about what in that transition of care. Yes, the way the way the last regulation was written, it's like, let's dump the junk drawer in a box and push it over and wash our hands of it. Right. It's more of, what do I need to know in order to give this person the best experience they can have, to make sure that their care, especially if they're changing plans and now they have to change their doctor. How can we make sure that we've got information that's going to support that transition? We don't want to take on the golden record. We don't want to be the source of truth for that clinical record. That's with the provider they were with. But if we can give that claims history over to the physicians so that they understand, or give them the notifications to know that this patient is diabetic on day one, I think we have a much better experience. So it's about what data makes the most sense and when, as opposed to we have it all, what do we do with it now? Yeah, we just got to get there.
Yeah, I think that's right on. It's very use case driven. There's very little clinical data that's 20 years old and actually that interesting.
Yeah.
So really, when you look at the immediate use cases, you mentioned coverage gaps.
Yeah.
So how do we react more quickly to gaps in coverage? How do we change the onboarding experience? You mentioned we should know what scripts you're on.
Right.
We should be able to work that issue. We should be able to help you understand the right entrance point because of care patterns that are involved. So I don't personally think the quantity of data is the question.
Okay.
Gosh, the system's evolution has occurred. We manage terabytes of data now very successfully. So it's not a quantity issue. For me, it's very much a use case issue. What am I looking for? And the critical thing, what am I going to do with it?
Right.
And so that's at least how I think about
I
it.
totally agree with that. I think we get millions of pieces of information today. A million more isn't going to make, the size, the volume isn't going to make any difference. I think our plan is to take advantage of the use cases we already have in place to say, okay, what is that problem list? And who do we need to get that to evaluate the problem list? What is the med list? What pharmacy rep our coordinator do we need to get that information to so they can evaluate what needs to be done for that patient? What are the risk adjustable codes that we need to be aware of so that we're beginning to work that aspect of the program as early on in the year as possible. Those kinds of things are in place because we get CCDAs every day, and we already mine those CCDAs or CDEX or however it's coming in. And so this is just additionally, I think the exciting thing about this, number one, is the timing by far. That's the great big advantage to payer is the timing of getting the data. The second one is getting that 5-year look back, which we don't get necessarily in an encounter record when they go to the first physician visit because they had a mammogram 3 years ago or they had a colonoscopy 5 years ago. By getting that information right up front, we don't have to over-message either the provider or the patient about getting those tests that have already been done with their other payer. So to me, those are the two big things that are going to happen day one to be able to improve the experience for the patient and the provider.
And I think the only thing I would add in addition is that, within our own organizations, even though we'd love to say no silos exist, we know that's not true. We have many, many users that have needs for this information, and they may not yet even know what those needs are or how the data is going to help them. So I think we have a lot more to do in the way of educating our own workforce and the workflows to get the data to the people who can make a meaningful difference to the member and their lives and their care.
All right, let's flip it around a bit. I mean, we've been talking about the data. We need to talk a little bit about the people. I mean, every organization is filled with 1 or 2 people who need to actually learn about new processes, and that's going to come. And as we build up more interoperability using FHIR, using TEFCA, what education do we need to bring to them? And not just the frontline people, but all the way from the front line right up to the C-level.
This comes down to a couple things. And I think one of the biggest questions that I have is, what is the member-patient expectation of what we're going to do with the data? So how our frontline needs to react, how our clinicians need to react, is very much centered on what is the expectation. And so the fact that you gave me a data set, which you may or may not appreciate what that even means, what do you think I'm going to do with it? So if you call our customer service line, what are they supposed to say? Did you get it? Sure, but right now there's I think a dialogue that's going to happen, which is, what is the patient's expectation of the clinician, and is it different because of this? Am I now expecting that you know something that you have is not in your clinical record today without doing a history and physical? And then the other part of this is the payer, in the more payer lens. I don't think our leadership is really thinking about this yet. And I think that there's a really fascinating bit of strategy that's going to come around because, as you said, this is data we've never had before, or more data than we've had before. Kaiser's a little advantaged. We've had a lot of this data over time. But what's the additional bit, and what does that mean that for us as a plan and how we're going to operate? And that's not a dialogue that's really, in my experience yet, occurred broadly across the industry and broadly across clinicians.
Okay.
I've been very, very blessed with a company that is solidly behind interoperability and has been for a while. But to answer your question specifically, I think there's 2 routes. So we're going to be getting this payer data. We're going to identify new use cases to do with it. I've talked about a couple that we are already working on being ready for, but I'm sure more will come out of the woodwork as we start getting the data. To be able to work on those and take the time to work on them, we have to have a value statement. We have to understand what the value is to the member, to the provider, to the plan. And that's the education we have to give to our leadership, right? They have to be able to say, yep, that sounds like the right thing to do. We're going to support you. That's going to be on the value. From an operational perspective, anytime we do a new capability, we have a structure where, as part of that project plan, the IT folks that have to support it get educated. We roll out through our markets to the folks that are what we call provider engagement executives that then become knowledgeable about the capability to be able to talk to our contracted provider partners, to be able to use the capability, and then operationally the business owners to educate their operations folks on how to use it. So that's just a process that we have had in place for a while, and to make sure that we get the communication and the education out to the folks that need it.
I would add that we've done, over the past 4 years, we've kind of made education a focus both at the association level as well as throughout the plans. And we've done everything from, you know, a lecture series, a connect-a-thon style event, and all of those have brought really good outcomes in terms of what we can do next with helping people to understand exactly what you were talking about, Nancy, the use cases and the value stories. You know, because I think we're kind of, I'm going to call ourselves enlightened, we understand what those use cases are, yet getting people to think through themselves how they do things today and how that will be influenced in a positive way by the use of clinical data is a strong force for helping people through education to understand where to go.
Sure.
Yeah, and that's an education that's ongoing and sometimes has to be, forced because we spend a lot of time. We spent the last 3 years building out that infrastructure for interoperability, and then our leadership will turn to us and say, okay, great, where's my data? And the answer, the uncomfortable answer is, well, if you had the data, what would you do with it? And then they stumble and stammer. It's like, that's the point, right? You have data already that you're not using. So getting more data, we don't want to turn our data lakes into data landfills, right? Because the second it comes in, there's a clock.
An expectation, right?
Right. It starts to get stagnant, starts to stink a little, and you can't make the same decisions that you could have made the day you got it, that now you're trying to make 6 months later. Or just like the problem we have with gaps in care today that's driven by claims, that you're hearing about what happened 6 months ago, and we're going through a list of things that we want you to take care of that you took care of 3 months ago. So how do we shift the mindset to when the data comes in, we know what we're ready to use it and we're going to use it, and we have it in pockets. We now have to scale internally so that everybody is thinking the same way about the data.
You bring up a good point, and you all touched on this, and that, I mean, everybody in this room is focused on making the world of patients better, right? Nobody's sitting here going, damn those patients. Too much focus on them. Okay, I am, just now. If we manage to get these roadblocks out of the way, if we make effective interoperability happen, how is this going to make the patient's life better?
Well, you use the example of the day after enrollment. You are now enrolled. We convinced you, or a broker that we work with has convinced you, you need to leave the plan you're on for our plan. Fantastic. Well, the day after, you start getting communication. Well, we got to find a balance, right? We don't want to be too creepy, too big brothery. But within a week of you enrolling, instead of waiting until the first time you present at the pharmacy and be told that the drug that you need to make sure that you don't spiral into an uncontrolled migraine, finding out when you present your card at the pharmacy in January that it needs prior authorization, and that might take 3 to 4 weeks. And now you're in a panic, because that happened to my family. My wife suffers from that. And we went through that experience, not changing payer. We changed from one United Healthcare product to another product. I shouldn't have said the name of the payer. I apologize for that. But we just changed products within the same payer, and we were locked into a prior authorization torment. And so we need to be able to take that burden off the patient, right? Take that burden off the patient, and then good things come with that. Right? We're insurers. We're kind of profit motive, right? So if you're able to get that patient into a process that you don't have to spend weeks of administration on, it's going to be better for the payer. It's going to be better for the provider. It's going to be better for the patient. And then now you start into getting the non-compliant patient into a program on day one, where you're communicating with them for 3 months before you even get into an encounter. That's a very different experience, and it's one that's going to pay dividends for everybody in this care continuum.
Yeah, the continuity of care,
Yeah.
the ability to understand where there could be discontinuous activity is really important. And I really like the notion that when someone comes in today, what do you know? You may know nothing. I mean, I know your social security number and your bank account number, but now you have a set of information we haven't really played with before on a brand new person. And so how do we use that to communicate more effectively with them? I think it makes finding a PCP really much more critical, because if you're going to use this data to inform someone about clinical events, you have to have a someone to go inform. So we'll change the nature of that. And I think it will also change how we outreach in the initial days of a brand new player coming in and really understanding the plan. And you can, when we explain how to effectively use Kaiser or whomever, now you can tailor it in ways that we couldn't have tailored it before. And I think that that has got a real opportunity for members and patients.
I think that's a great response, and when I was thinking about this question a little bit in advance, we know that patients, like anyone else, adopt technology at different rates. You've got some of those that are waiting for the paper records still to be delivered to them by mail, and they're perfectly happy and don't quite know what to do with them when they get them. On the other hand, you've got some people that are right at the wrist waiting for, what is my test result? Now, what do I tell my doctor about this? How do I coordinate my own care? That's where we need to get. Unfortunately, and I thought about this a lot yesterday as I was listening to the consumer engagement and consumer voices, some great stories there. Those are individuals that know how to advocate for themselves. They understand, but we have many people that are not yet there. So in our efforts to bring the data to the members and the patients, consumers, whatever nice word we want to use, we have to make sure that we really are hitting that very basic level of, why do I care? I've got this information, why do I care? And I feel like that's where we'll have a lot of work. I'm excited about the consumer engagement group. I volunteered for that because I want to see that foundational effort there.
I mean, I really like what you were bringing up about pharmacy. I think this payer-to-payer capability, when I think about Humana exited the commercial business this year, I'm sure everyone knows that. That meant me as an employee of Humana got a new insurance plan with a new company. And the first thing that was my aha was, oh, I have medications that I have to take every day. Are they going to be different? Or is the process going to be different? So knowing when we get that member register or they enroll with us that we get that medication list, and we have algorithms in place to say, look for these drugs, so that if they require prior authorization or if they require if they're specialty compounds or whatever, that we get in touch with those folks right away and help them have an assurance that they're still going to be able to get their medications, and we're going to do it in a timely fashion. And then the second aha moment for me would be, what about my oncologist or my cardiologist or my orthopedist or whoever? I'm right in the middle of some kind of care. And so if we can look at those situations and through AI or some other time to any of our technologies to be able to filter through the data and say, let's identify these patients that are really critical that we reach out to right away and give them that feeling of support, comfort, knowledge of how we're going to help them continue their care without interruption. So I think that makes payer-to-payer kind of invaluable.
All right. Now, we started off this by explaining that Sequoia is putting together the payer-to-payer API workshop. And we're co-opting all of you into it. I hope you're ready for that. And if you're not, sorry. I'm Canadian, I have to say
Canadian, sorry.
Using the Sequoia project as the convener of this, how do you feel that we can, as a Sequoia project, help you get through these roadblocks?
This doesn't work without a trust network, right? So we put our APIs up, we publish them, It's out there, and now to do that exchange, I've got 1,500, 1,000, or 2,000 different payers I have to communicate with, unless I have a trust network I can register with, and now that exchange can happen. Again, it's about eliminating making it easy for the exchange to happen is where Sequoia comes in.
Absolutely,
there's
access. I'm sorry.
Yeah, there's a lot more endpoints than we've had to deal with before. And I'll make a quick pitch for the CEQ endpoint project, because they're trying to be a convener and provide access to all the endpoints so that I don't have to go discover them myself.
Right.
But that's one of the barriers. But how Sequoia, I think it's awareness. And I also wonder I don't know how many Americans change health coverage a year, but it's a really big number.
Yeah.
I wonder how we really effectively communicate this opportunity broadly. Now, we'll do it as inbound plans, but how do we create the understanding that you want us to do this? We're not secretly, wringing our hands, we'll get your secret medical information.
Right. I can deny everything.
Yeah, exactly. So how do we get the positive spin to millions of Americans who change coverage every year?
And I think the Sequoia project is really perfectly suited to be that kind of integrator between the many arms that have to come together to get payer-to-payer exchange going. We talked a lot about trust. We've heard about that for days. And that trust and building trust between entities that haven't necessarily had the motivation or the reason to work together in that kind of manner is going to be critical for the success. I think Sequoia is well suited for that role.
Great.
And I think it's about access. I think Sequoia and TEFCA, if there were 4 major payers in this country, we wouldn't need a convener, right? I mean, we can already connect to the big payers that we work with every day. But there are, I think, 400 payers in this country. I think that's about the right number. And the rule doesn't say you only have to connect to the next 3 big ones around you. It says you have to connect to everybody.
Right.
So having a single on-ramp, having the help to get to all those payers, and thank goodness we have that many payers in the country, right? It gives us all choice, it gives us all options, and that's wonderful. But it also, for this kind of project, creates the complexity of being able to find all those people and share your data with them and get their data back. So having the single on-ramp, having the QHINs and TEFCA to be able to bring us all together and give us all an easy and definable way and support to get connected is what's going to make this happen.
Great. All right. Just want to thank you all. I want to let people in the audience know that if you're a payer and you're interested in this, we're going to send out a questionnaire to all the payer members of Sequoia. We want your input into what we're going to be working on. We want to know where you are in the process, what and what you think the process is. We're also working with, potentially with partners to get it out to the wider payer community. If you can fill in this questionnaire, we would love you to death. If you can't fill it out, we'll still love you. But join us starting Q1 next year, and we'll get this going. Thank you so much.
Thank you.